Good morning. How are we? That was such a generous introduction, Paul. Thank you. And thank you to the MLP staff for having me. It's such a joy. I want to try and get right to work because I know that we have a lot of ground to cover. But I would say before I start that it is very natural for me, as it is for Paul, to be in this room because I too feel like, duh, lawyers, healthcare providers, those are two populations that go together. And I was thinking about, gee, why does that feel, so deeply innate to me? And then I thought, my mom is trained as a nurse and as an attorney. So I have these two populations literally at the dinner table all the time in conversation with me. And it's great to see all of you here continuing that dialogue. I do just want to start by pointing to the graphic on the far right is the book that has really enabled me to be present at conversations and conferences and summits like this. And I'd like to recognize my co-author is Elizabeth Bradley. She's a professor at Yale School of Public Health, and she would very much like to be here with us today. I know that this is one of her favorite things to do as well, but she is my co-author and total partner in crime in this. And additionally in the room today, we have Boyd Jackson, who worked as an RA, but an RA doesn't quite cover all that he did on this book. Really a very close collaborator, so I haven't seen him since the book came out, to be quite honest. So he's in a doctoral program at UCLA, and it's great to see him and have him here too. Okay, let's get to work. So the outline for today, I think I have just about 35 minutes, 40 minutes. This is what I was hoping to cover, and forgive me for glancing a little bit. I have some small text here. I'm going to try and hodgepodge it together here with the small text. But the outline for today is roughly as follows. I'll start with some framing comments on what is the American healthcare paradox. We named the book this. Everyone in the book publishing industry said, don't name your book the American healthcare paradox. No one knows what it is. But it's given me a really nice entry point for talks like this. So I'll start with that. What is the paradox we're talking about? Then I have three kind of chunks of data, if you will. So as a researcher, this is where I'm comfortable. I think I can present three tiers of evidence that suggest that targeting non-medical determinants of health is really a savvy way to go about redesigning the health system such that we can get better health outcomes for a reasonable cost. And those three levels are, there's an international data set that's been published and is in the book. There's a state level look, which is not yet published. It's under review and should be out in the peer review literature shortly. And then there's some program level data where we've looked at individual case studies of groups like MLP, collaborations between housing and healthcare and other kind of on the ground providers who are doing this hard work. And then I think I want to close with just some brief comments on the policy environment. Is it moving to a place that is more supportive of MLPs and other programs that are integrative like it, less supportive? What might we expect and what might we want to keep an eye on? So that's roughly the plan. Sound okay? Yeah. No one's going to tell me no. I love it. All right, so what is the American healthcare paradox? The president summarized it really well, and I think it should be well known in the room at this point, but this was back in 2009. He said, then there's the problem of rising cost. We spend 1.5 times more per person on healthcare than any other country, but we aren't any healthier for it, right? This is a familiar sentiment now. So just so we're all on the same page, what is he talking about when he says we spend 1.5 times more per person on health? Usually it's a graphic like this that he and others have in mind. So along the x-axis here, you have all of the OECD countries, the Organization for Economic Cooperation and Development. Those are sometimes referred to as the industrialized countries. And on the y-axis, you have the percent of their gross domestic product that they spend on healthcare. And this is the graphic that says, oh my gosh, we spend so much on healthcare in this country, it's ludicrous. We're up around 18%, whereas the OECD average is around 12 or so. This is 2009 data, but the numbers haven't really moved that much, thanks in part to the recession. So this is what we're talking about when we say we spend so much, right? And then when the president and others say, but we don't get very much for it, what are we talking about there? Usually we're talking about the big population health metrics that public health officials like myself like to point to say how healthy is the country. And when you look across the OECD in these kind of big buckets, maternal mortality, we're 25th. Life expectancy, we're 26th. Low birth weight infants, we're 28th. And remember, this is out of 34 countries, right? So total transparency, you could pick a different set of metrics that would make the investment look like maybe it was doing some good, right? So if you want to look at kidney transplants, knee replacements, any kind of really process-oriented thing where the more volume you do, the better you probably get at it, Those things are things that we do well at. But the real tried and true measures of how healthy is the population, how long are we living, what's the quality of life, very, very poor. And just to be clear, I don't think that I'm manufacturing this problem. So sometimes folks will look at this and they'll say, that's interesting, Lauren, but if we're talking about industrialized countries, you know, how bad is bad, right? 25th, 26th, maybe it's not really something that we should spend time and energy on. So at the bottom of this slide, I like to put where we fit in the global rankings, right? So I can't fully read this, but maternal mortality, we're 138th, I think. 36, thank you. And we're just one nudge in front of Hungary and one below Iran. So that means Iran's maternal mortality rate is better than ours, to be totally clear. Life expectancy, we do a little bit better. In the globe, we rank 42nd, and that sandwiches us between Finland and Turks and Caicos. Those are kind of our buds around that level. And low birth weight infants, this is the one that always gets me, 169th in the world, and that sandwiches us right between Guam and Croatia, right? So I do this just to really emphasize the fact that when I say we're not doing well, we're really, I think, not doing very well. And so here I just try and say, this is a paradox, right? And the reason we think it's a paradox is because traditionally we've thought if you spend a lot of money on healthcare, you will get good health, right? That has been the fundamental assumption underlying the whole system. And so essentially, the reason that we find this so shocking is because we equate these two things. We think healthcare and health are one and the same. And the big project that Betsy and I and Boyd and others have been undertaking for the past few years is to try and wrench these things apart, say healthcare is great, it's part of the equation, but healthcare and health are not the same, and greater investment in healthcare obviously does not necessarily get us better health. So at the beginning of this whole journey, which was now, I think, almost 5 years ago, Betsy and I started to think about, okay, if you were to do domestic healthcare reform, it's important to know where we've been. And these problems with the big population health metrics have been acknowledged for decades and decades and decades, right? So this is not new news that our maternal mortality or life expectancy is bad. It's not as if we've recently plummeted. We've kind of always been underperforming. And so what have the suggested kind of reform efforts been? And this goes all the way back to the 60s, Medicare and Medicaid. They've been things like, we should insure more people, right? We should have a single payer. No, it's all about making the markets more competitive. Or for the lawyers in the room, it's all about tort reform. But there's something really binding all of these interventions, and that's why I've put them in a box here. All of these proposals are really working on the healthcare system. They're trying to make it a more efficient marketplace. They're trying to get people access to more healthcare. And those are all good things. But the question that we asked ourselves was, what if the problem isn't all about healthcare? What if we thought about this differently and said there might be something outside of the box that we've been missing but could be a real leverage point? And if you go to the conceptual literature in public health and some empirical literature as well, I think there's good evidence to think that there are things outside of healthcare that could provide a leverage point. So if you think about what determines health, some of you will have seen this graphic already, but often people will bucket it into three groups. You have some percentage of your health that's really determined by your health care, some percentage that's determined by genetics, and then some that's determined by things that are not either of those two things that I'm calling social, behavioral, environmental determinants of health. And so the breakdown sometimes surprises people, although I'm not sure it will surprise folks in this room. When you're thinking about what determines health, about 20% is your health care. How good is it? How much access do you have? You know, do you get to the right specialist? Do you get there in time? That's all healthcare. About another 20% is determined by genetics, right? So this is just you're born with something, you've got BRCA, or you've got another genetic mutation. We now know that actually the environment and the genetics are very linked, but for now, let's leave this as a bucket on its own. We'll say it's about 20%. But then the vast swath of our health is really determined by these social, behavioral, and environmental determinants, which we have so long overlooked when we try and create health reform. And so concretely, what would go into this bucket? It would be, what's the air quality like? What's your BMI? Do you smoke? What's your social network look like? Are they walkers? Are they not walkers? Are they fast food eaters? Are they not fast food eaters? All these things fall into that bucket, and they have really traditionally been ignored. So Betsy and I, in looking at the graph that I showed you earlier, when we look at this graph, which has been everywhere on the cover of every newspaper, And we thought about this paradox. We said, well, is there something that's not captured in this presentation of data that we should be trying to capture to really understand the paradox better? And we thought, well, it would be nice to come up with something that could build into the equation the attention that each country spends on those social, behavioral, environmental determinants, because that's nowhere here. This is all just the effort you put into that one 20% sliver. So we were thinking about this. And fortunately, in the OECD data set, there is a way to build that in, or to at least build a proxy measure in, right? We could take a hard look at what each country spends on social services and try and integrate that into the analysis to get a fuller picture of what each country does to really build health for the population. I won't go through this in much depth, but I would say we're just completing a literature review that looks hard at what is the evidence for each of these social services? What is the evidence for housing? What is the evidence for things like temporary assistance for needy families, other income supports, food supports? And in fact, the evidence is really not bad. You know, it's not something that's been studied a ton for decades and decades because people haven't always been thinking about these as levers for health. But there is evidence, and high quality evidence, for all of these interventions that when you give folks, particularly low-income folks, some of these supports that are social, behavioral, and environmental in nature, even if you do nothing for their health care, their health improves. So keep an eye out. This should be published in the next few months, but the literature is there. So if we go back to this again, which we've now seen three times, I just want to make sure, because I'm going to change it on you, we're all clear. The US is way on the left-hand side if you just think about healthcare, right? Now, what Betsy and I did in the book was say, let's build the social service spending into the analysis. If you do that, the picture changes. So what you have here now is all those OECD countries on the bottom, still percent of GDP on the y-axis. The blue bar is your percent of GDP spent on healthcare, and then the orange bar stacked on top is the percent of GDP spent on social services. And so you'll see the United States has moved from being the biggest spender to somewhere in the middle, right? So this is interesting, but it doesn't seem to, if we thought that this was the full story, you would expect US's health outcomes to be kind of middling in the OECD. But we're not. Like when we're 28th in low birth weight infants, that's really close to the bottom. So we thought, well, if we wanted to yield one additional insight, we could potentially take the ratio of the bottom bar to the top bar, so the healthcare spending to the social service spending. And if you do that for each of the countries, this is what the graphic now looks like. So the US has the lowest social to healthcare spending ratio in the OECD. And so this, if we think this is important, is a very different picture of how the US is performing in terms of its spending. Whereas we usually think we're this huge spender, on this metric, we're the lowest, we're the least. And so that's interesting, right? To summarize that specific graph, in the US, for every $1 spent on health services, about 90 cents is spent on social services. And if you were to take the OECD average, for every $1 spent on health services, an additional $2 is spent on social services. So this is just a radically different allocation profile that we have in the United States. And this is another way in which we're an outlier. We know we're an outlier in terms of healthcare spending, but we're also an outlier in terms of this allocation pattern. Now, for statistics folks in the room, Paul said we're health nerds. I hope you're really nerdy, because I am taking you down the nerd hole. Does it matter, right? If you plug it all into your statistical package and you say, is this ratio predictive or associated with good health outcomes? It is. And it's particularly associated with low infant mortality, less premature death, longer life expectancy, and fewer low birth weight infants, right? So these are things that we traditionally have not been very good at. Okay. We're through one part of the data. We still good? Yeah. Anyone dying on me yet? All right, we're going to do it again. So now the question is, can we replicate this at the state level, right? So we presented this data, the book came out, everyone said that's a really interesting metric that you guys have come up with, this social to healthcare ratio. What about within the United States? So there is a paper that's forthcoming where we've redone this analysis with the help of an incredible team of epidemiologists at Yale School of Public Health, who I wish were here to present this with me, because I am not as quant jockey as they are, but this is their work. You can create the same ratio of social to healthcare spending within the states. And what this map shows is if you create that ratio and then you list all 50 states and you break it into quintiles, so the bright green is the top 10, so the best, if we want to use normative language, the best, the people who spend most in the way that I would think is effective and the evidence shows is effective. And then you go down, so the red states are the ones with the worst ratio. They most prioritize the healthcare. So we can do this, and we made these very fun maps. And then with this kind of heat map, once you have the metric that we like, you can compare it with some of the health outcomes. So on the left is that same graph that I just showed you on the previous slide. On the right, you see percent of population that's obese. And again, you see a bunch of overlap, right? So a lot of that Bible Belt, unfortunately, we see. And these maps stay really similar if you go through asthma admissions, if you go to days of mentally unhealthy days, certainly life expectancy. There's a lot of this overlap again. And I would say, because we've just walked through it on the international level, I don't have to go into much depth here, but if you run the same regressions and you try and find the same associations, it holds, right? So states, again, just like the countries, states with higher ratios of social to health spending have statistically better health outcomes. And the metrics that we looked at, and the metrics we looked at in this paper were lower mortality among those with lung cancer, asthma, obesity, mentally unhealthy days. These are all things that are high-cost conditions that make us think that this metric may be really telling us something. And I want to just pause for one moment because I like to be clear that the metric, the social to healthcare ratio, is, I think, a proxy measure, right? I don't think we need to be really literal all the time about, well, what is the ideal ratio, right? Should we all be trying to get to the same thing? Because it's very tough. If you look at a state like Massachusetts and you're talking about social to health ratio, it almost always looks like a bad performer, even though the health outcomes are actually really strong. And why would that be? Because when you're working with a ratio, the bottom in healthcare, the healthcare spending in Massachusetts is so heavy. We have so many academic medical centers. We have so much healthcare infrastructure that the ratio always looks like it's not that good, even though the health outcomes in Massachusetts are good because our social spending is also quite generous. But the ratio will never look the way we want it to. So even though I'm a champion of this metric, I think it tells us something interesting. I never want it to be overdetermined or for us to feel like the ratio is the end-all be-all. We have to find the magic number and get there. So I would say the good news here, in light of those comments that I just made about the ratio not necessarily needing to be interpreted so literally, is that we may not actually have to move money from one sector to the other. So a lot of times when you get with policymakers, if there are any policymakers in the room, I apologize, they're very literal, right? So it's like, okay, you've given me a ratio. How many dollars do I need to move from top to bottom or bottom to top? And I don't know that that would be the worst thing in the world, but I think it's just such an uphill battle in terms of politics, trying to wrestle money away from the healthcare industry to put it into social. It's not a fight that I necessarily want to fight, even if I think the outcomes could be good. So I think what we could do instead is exactly what so many MLPs do, all MLPs do, in fact. And the gist is you can integrate, right? So people can more or less, the sectors can more or less keep their dollars. We don't need to redo budget lines at the state level, but we could integrate. And in fact, there's a lot of evidence to say that a whole host of integration models also have an evidence base for being able to improve the health of populations. So just working from the traditional healthcare sector, I've tried to make this slide such that you have traditional healthcare where the doctor just kind of writes you your script for the pills and they'll do the tests. And then moving this way, you get to kind of more and more innovative thinking about the ways in which integrative services could work. So you have things like community outreach, right? That in and of itself, we kind of take it for granted, but that is an innovation in a way because 50 years ago, I don't know that many kind of programs were going out into the community. You might have home visits from a primary care doctor, but there wasn't this real emphasis in mobile vans and community outreach. Then you have case management, care coordination. This is also a new kind of component of healthcare services that is trying to at least move towards the integration side. You've got some healthcare institutions offering individual social services. So for instance, forgive me for relying on Massachusetts, that's my home state, so it's the one I know best. Boston Medical Center has a food pantry, right? And so this too is kind of an integration activity on a small scale, fairly limited, but important. Then you have programmatic partnerships, which I think MLPs fit squarely in that basket. Programmatic partnerships, which can in and of themselves be arranged in a diverse set of ways. Some are contractual, some are pooled budgets, some are not. But that has an evidence base that is built on MLPs and a whole lot of interesting partnerships between healthcare institutions and housing departments. And then you can keep going out, co-location of services. We've got a case study of that in the book if anyone's interested, rooted in the Veterans Affairs Administration. And then all the way out here, this is a little bit of a pipe dream. Maybe it's a lot of a pipe dream, but I put it there because this is the model in Scandinavia, right? So you go to Norway, Sweden, Denmark. These are the stars of that OECD data set. They're the ones that spend the least and get the best health outcomes time and time again. And the way that they do it, quite frankly, I think this is the key. At the local level, they pool health and social service budgets based on geography so that each geography can make really informed choices about how to best pursue health on behalf of their population. So they can do housing if they think housing is going to have a larger effect than the latest proton beam therapy. And because they're geographically bound, you know, the Florida of Denmark can really cater itself to services for senior citizens, and the not Florida can really focus on early childhood education. So I think this is key. I think we're a long way from that, but it's worth putting out there. So common barriers, I just want to acknowledge, based on the kind of case studies and the conversations I've had with folks who do MLPs and do other kinds of integrative work, I'm sure you guys could do this slide better than I can, but I wanted to at least put out there that I know the fight is hard. There's a few common barriers that come up time and time again when you talk to folks. One is developing political capital is really tough, right? Especially because often when we talk about this, policymakers and CEOs of hospitals will say, yeah, but that's all about the poor and there's no money to be made on the poor. I hate the term the poor, by the way, but I use it as a parroting of what folks have said to us. And I think while there may be a lot of money to be saved on folks who are low income, and the ways in which the social, behavioral, and environmental determinants impact their lives are most obvious, most capturable, there's no one in the world who could not benefit from a more holistic approach to health, right? And if you look at the other side of the socioeconomic gradient, this is very much in vogue. You know, you go to Whole Foods and it's all about the organics and the yoga and a healthy lifestyle. There's a lot of upscale gyms and things like that, New York, LA, where you go, you can see your chiropractor, your nutritionist, your primary care guy, and you can work out and you can get a smoothie on your way out. It's the same concept. It's the same concept to me, and it's just playing out in different ways. The second real common barrier are technological limitations. You know, we don't share an electronic medical record, or often, oh, we couldn't possibly share information with the homeless shelter because, you know, HIPAA. Which I always go home to my mom, she's like, oh, they're crazy. I'm confident lawyers in this room could help work it out, but I think that's something that we hear a lot of, right? Then there's the differences in culture and professional norms. This is a big one, and we hear it a lot from especially ED docs, right? Yeah, we would love to discharge someone who we know is in a vulnerable state to a halfway house or a shelter or to some other program that can really take them in. But guess what? I'm here at 2 o'clock in the morning. I want to get this guy out of here, and there ain't nobody over there at 2 o'clock in the morning picking up the phone. They work a 9 to 5. I'm here on 24-hour shifts. There's that kind of a little bit on the high horse from the healthcare side. But there's also an on the high horse from the social services side when they say, those folks on the Hill, the hospital, they're big money, they don't care, they don't know what life is like in the trenches. And so we've heard this time and again from both sides of these potential partnerships. The other person or the other group does not understand me. And then there's the non-alignment of incentives, which of course is the elephant in the room. And I do really like this quote. It came from the book, and we were doing interviews with folks at hospitals about the ways in which they had tried or are trying to integrate. And they said, this interviewer said, we had a really successful outpatient diabetes center, so successful that it reduced the number of hospitalizations, amputations, et cetera, dramatically. So the hospital shut it down because it lost them money. It's funny, but it's sad. And so I just wanted to say, these incentives, I acknowledge, have been misaligned for a very long time. When we get to policy, I think there's reason to be optimistic that this is changing, but historically that has been a real problem. Common features of integrated innovations, again, you are all in these, so I won't spend much time, but there are a few that I would just highlight. One is you have an interdisciplinary team as part of these programs that are integrated and doing good work and seeing the evidence. You've got an interdisciplinary team that identifies as a blended unit. You've got newly defined organizational and professional responsibilities, and this I think is key. It's not enough just to say you're a good lawyer and you're a good doctor, so now you can work together. There's going to be new tasks on both sides. The lawyer's going to have to do something that they haven't traditionally done, and the doc or the nurse or whatever the provider is, the social worker, is going to have to do something they haven't traditionally done. There's going to be a task added, there's going to be more time required, and we shouldn't shy away from that, right? Because that's just a legitimate thing that seems to happen time and again, and if we tell each other, oh, you can just be a great lawyer and I can be a great doctor and we can work together beautifully, we're lying to ourselves. The programs that we've seen most effective have agreed upon goals and metrics based on outcomes rather than services. So again, this is trying to push us away from the way services have traditionally been delivered and incentivized and paid for in healthcare. You focus on, is the person healthier, in a better spot, having a better quality of life? Not, did they get the test? Did they get to court? Did they get to whatever? Sustained efforts to try and make the business case. I think this is really key. I'd love to talk about it more, but in the interest of time, I'm going to keep going. You just have an eye towards how can someone take this on and we can get out of a philanthropy model or we can get out of grant funding and we can really say to the CEO of the hospital or to the CEO of the law firm, this is going to be good for you in the long term. And then the programs that do the best at this, I think, time and again, I've noticed they have a real ethic of client empowerment and patient-centeredness. If you keep the focus on what the person actually needs, it's always incredibly obvious that they need both sides. They need both services. And in fact, they need more than probably just two things. They need a whole host of them. And if you keep your eye on the patient or the client, that will keep you motivated and focused on the right things. So collectively, that's the end of my data section. This is my big sum up from the data. Collectively, I think this research suggests that greater attention should be paid to non-medical determinants of health if we want to curb the growth of health spending and maintain or improve quality, right? So I've given you the international, oh, I'm not even done. Thank you. So I've given you the international look, the state level look, and then the programmatic. So just a few minutes. How many minutes do I have left? 5? Oh, great. So a few minutes left on policy and whether policy is going to swoop in and help or continue to be an impediment. I would argue that we are headed in the right direction on the policy front, right? And so Obamacare, the ACA, Affordable Care Act, however you want to term it, I think a key ingredient that we sometimes look over when we talk about Medicaid expansion and the expansion of insurance and the insurance market reforms being the big thing, I think we forget that one of the other big things is that the ACA has all sorts of mechanisms built in to try and move healthcare away from a fee-for-service industry into some kind of a value-based financing model. And so concretely, if you look at CMS, they've come out and said, we want 50% of the work that we've traditionally done that's fee-for-service to be in a value-based financing model by 2018. And in their Medicare programs, that's even higher. I think the number is somewhere around 80%. So they are aggressively trying to move away. These incentives have been flawed, and they've been recognized as flawed for so long, but this is starting to make some incremental shifts. So that's my big thing on policy. I think we're moving in the right direction. But I'm going to tell you the ACO story as I know it in 4 minutes, just to ask, you can say we're moving to value-based financing. That is good in so much as it is not fee-for-service, but there's still a question to be asked about what do we value, right? What is the value that we're trying to go after? What are we chasing? So in the ACO story, I think we see how we're trying to push towards value-based financing, and we might have even gotten to value-based financing, but we didn't actually get all the way to population health, which was what we said we wanted to do, right? When the ACO was born, it was largely headed by, at the time, the head of CMS was Don Berwick. He had come from IHI in Boston, the Institute for Healthcare Improvement, and he came with this real emphasis on the triple aim as kind of a framework for improving the health system. He said everything in healthcare should be focused on 3 things: the experience of care, the per capita cost, and the population health. And this population health idea was new. And it got integrated into the bedrock of the ACO in the early documents, if you look back at how CMS was talking about it and planning for it and actually rolling out the accountable care organization. And here's why I think population health is exciting. Generally, when people talk about population health, there's a lot of different definitions being thrown around. I would say for it to be population health, you have to be focused on an outcome, a true outcome, like life expectancy, quality of life, maternal mortality, all of these stats that I've been talking about today. And you have to be looking across a fairly large population. Exactly what that population is, whether it's a patient panel for a hospital or it's a state or it's a country, we can kind of quibble about that, but that's what I think population health is. And the reason that I'm excited about population health, and I was particularly excited about population health in the context of the ACO, is as follows. Traditionally, like I've said earlier, what we've thought about in the country is you take a person, you apply healthcare to them, and you will get health, right? But in the ACO's early days of talking about population health, what I think it allowed for was some real creativity about how you get to health. Maybe you don't always have to drive through healthcare, but if I'm an ACO and I'm really incentivized based on population health, I may say, you know, we should really be talking to housing. We should really be talking to legal aid. We should really be talking to the schools. Because if we're really held accountable for people's health, they may really have something to do with that. You know, and if they listen to me, they would say they have 60% of the kind of oomph trying to get us to health. So this is why I think that putting a flag on population health and saying this is what we're going after is really critical in general from the system perspective, and a real opening for everyone here in this room who works not in the healthcare industry but thinks they have something to provide. And how do you measure population health? I'm sorry, this graph is a little bit, or this slide is a little bit ugly. It's taken from the Institute for Healthcare Improvement, but I would say we know how to measure population health, right? We measure it by health status, functional status, life expectancy, burden of disease. But when it came to the ACO actually having to have measurements and incentives layered on top of it, when they said, okay, now we're actually going to pay for something, it's not just a concept, but we're rolling out, and there are now 600 ACOs in the United States, CMS said there are 33 quality metrics that we are going to collect information on, and here's what they are. So all the blue, I would say, is they're looking at healthcare quality, and then they have one metric, ACO quality metric number 7, is health status and functional status. And so this is where I think we fell a little bit short, right? We said ACOs are really going to go after population health, but then when it came to the rubber hitting the road and how are we going to measure these folks, we kind of let population health drift aside, which we should all think is totally natural, right? If we've always, for decades and decades and decades, thought that healthcare and health are the same, this is that same idea coming back to bite us in the butt again. So this is what the ACOs have been required to report on. Then in years 2 and 3, I believe, CMS said, we're going to pay you for your performance on 32 of the 33 metrics, right? So we've taken the baseline, and if you improve, you're going to get your money back. You know, you've bared some risk, and this is the whole idea. Which one do you think that they didn't pay for? Right? They pay, not paying for health status and functional status, right? And I think this is kind of a granular, wonky policy story, but it's really telling about this is value-based financing, right? This is not fee-for-service. This is progress, because now the healthcare industry is having to perform on certain metrics, but what we're valuing is not yet actually population health. It's still kind of in that realm of we want you to deliver high-quality care. Good, not all the way there, right? And so what happened to this model, the ACO model? And I would say you could talk about this in relation to a lot of models, but you saw this graph earlier. What happened? Initially, when Don Berwick was there, kind of leading the charge, and everyone was really geared up about the ACOs, we said, ACOs, you're going to be responsible for population health. You've got all of this stuff to worry about. You've got the healthcare, the genetics, and all this social behavioral stuff. You really need to pay attention to how long people are living and what their health status is. And then when it came to actually implementing the model and designing the nitty-gritties of how it's paid for and what kind of data we're collecting, we went back to, okay, actually no. By and large, you are responsible for healthcare and healthcare quality and providing high-quality care. This is a totally noble goal. But it still remains unclear in the ACO model who's going to do this 60%, right? And I just want to be really clear, there is nothing wrong with incentivizing healthcare organizations to provide high-quality healthcare. No one would say that that's a bad goal. I love that goal. And in fact, the more I talk to healthcare folks, it's not necessarily even that they don't want to do it, but they really feel like that's not what I'm trained to do, right? So, you know, this foisting of health as a responsibility onto healthcare may just be totally inappropriate. You know, I would love for this swath to be assigned to someone. And it would be logical, or it would be easy to assign it to the ACO or to healthcare generally, but that may not be right. It may be other folks. And my thinking was, if you assign it to healthcare or the ACO, then they're going to figure out a way to kind of outsource that responsibility by building relationships with legal aid and education and housing. But that may have been a pipe dream anyway. But I think it's still a totally open question in the literature and in the world, who's doing this piece and how can we link it with the people who are responsible for this piece, right? So just some concluding thoughts, and then I'll get off my high horse here. Oh, that was a secret. Okay, here are my concluding thoughts. In order to be doing really innovative work like medical legal partnerships, you have to fight against policy frameworks that are less than fully supportive, right? I know that the policies, I just gave you a story of how it's not there yet. It's not fully designed to support population health. It's not fully designed to operate on the evidence base that I've been part of building, but is really much larger than the book or my work or Betsy's work or Boyd's work. There are decades of literature saying these social determinants of health are really, really important, and the system does not work that way right now. I would urge you to remember that researching and sharing your experiences will allow and has already allowed for some of these policy shifts to happen, right? And that's part of my job, and that's what I love about my job is I love talking to folks and having them say, well, we did a study, and it's small and it's in the gray literature, but it showed great impact. Our patients are healthier, our clients are healthier. Then part of my job and other people's jobs is to really cull that evidence and take it to policymakers and say, look, this is working, this is the evidence base, you have to move. But it's always a fight. And I know that it's not easy, and I know that not every legal aid firm has a research staff and professional evaluators and biostatisticians, but I would urge you just to keep it in mind. Find someone at your local school of public health, they'll love you. And the last thing I would just add is, if you weren't bumping up against less than fully supportive legislation, I don't think it would be innovative work, and I don't think it would be as exciting as it is, and I don't think you'd have 400 people in the room. You know, it's because you are right at the cutting edge that these policies are not yet there yet. They're trying. I think on the whole, we're getting there, but I know they're not there yet. That doesn't mean you shouldn't keep up the good work and continue to lead in this area. So thank you. Have a great summit. I'll catch you at coffee.